prostate and in prostate cancer, the androgen receptor signaling is extremely important. Don't forget it is a sexual accessory organ, so driven by the male hormone, the main male hormone being the testosterone. It is already like this in the normal prostate. It's even increased in prostate cancer. And most of the cells, they will actually induce a process of cell death if you suppress testosterone. And it has been the base of the treatment for 60 years of prostate cancer, removing testosterone. However, there's something to mention is that we have realized in the last few years that beside that AR-dependent pathway, there are a lot of AR-independent pathways that probably make the cells resistant to that old treatment. But in a vast majority of patients, the AR is one of the main drivers of the prostate cancer. If you want to interfere with the AR pathway, it's easy. The first thing you can do, you suppress testosterone. That's castration, surgically or with drug that block the production of LH-FSH. If you do that, there is still the possibility that the cell will produce its own androgen or use androgens coming from the adrenals. If you want to block that, you have to use drugs like abiraterone or galeterone. You're going to use this drug on top of the castration. Third mechanism, you can act directly at the androgen receptor level by using antagonists, so drug that instead of DHT will not activate it but block it. This is old generation anti-androgen, such as bicalutamide, flutamide, enlutamide, and you have new generation, much more potent, enzalutamide, ODM-201, ARN-509. One of the most important questions nowadays is what's the difference between the AR regulation in hormone-naive versus the AR regulation in the castration-resistant. What we know is what's happening when you suppress testosterone. When you're suppressing testosterone, it's creating pressure on the androgen receptor. And one of the most common response will be AR overexpression or AR amplification. The cell will make more AR. That's the number one mechanism. On top of that, you have other mechanisms, AR mutation, cofactor mutation, increase in non-AR dependent pathway, so that we know very well. What you don't understand very well is when is it happening. Is it happening shortly after you suppress testosterone the first time, or is it accumulating over time? Because the study we have, they compare hormone naive to hormone resistant, they usually don't address the dynamic over time. And it appears now that that dynamic is more and more important. To understand the implication and the treatment's opportunity with AR reactivation is that you block the AR by suppressing testosterone, so you basically shut down the system, and then slowly the system will reactivate itself, either by using small amount of androgen or even ending with auto-activated androgen receptor. And these are specific mutations, or for example, splice variant, which are truncated AR, which do not bind the testosterone. There are 3 parts in the AR, and that part binding the ligand may be lost. So when this is activated, basically is just like you restarting the progression machine. So you're stopping the progression, and the cell find way to fuel itself without testosterone. And that now we understand very well, and we have drug to block that specifically, which is very interesting. I think that basically people speak about 2 generations. I would say 3 generations, and we were now moving to the 4th one. So first generation of drug were drug suppressing testosterone, working on the brain. Second drug were first generation anti-androgen such as nilutamide, bicalutamide, flutamide, that were basically developed from normal cell. Third generation, enzalutamide, ARN, and ODM-201 were developed from AR overexpressing cells. So cells that were already castration resistant. So they have been specifically developed for castration resistant cells. Although they have a major limitation. They still act by binding to the ligand binding domain. The fourth generation of drug will be drug developed to target the non-ligand binding, like the DNA binding domain or the N-terminal domain, which seems to be more preserved in castration-resistant. So the next generation will be drug that block the AR, but not through the traditional ligand binding domain.